Billing and coding. For today's lecture, we are going to talk about the recent changes that happened in 2021. Before, if you hear my talk, it's my pleasure to come here almost every year to do the talk. You will hear me talk about too many bullet points and how many you have to do and check here and there. Today is a little bit different because the guidelines has changed. So it's going to be dramatic shifts from what we used to do, and the slides has been updated to reflect the changes for the outpatient setting. The inpatient setting did not change much. Today, talk is going to be mainly for the outpatient. We will do different presentation at a later time if the time allows for the inpatient and for the nursing home and for the extended uh, billing services and high complexity and coordinated care codes. Today, my focus, because the changes has been significant, I rather to devote this time to talk to you about what has changed in 2021. So we are going to learn a little bit about those new guidelines and what the medical decision making means as far as CMS concerned. So the medical necessity as defined by Medicare is you need to document what you are doing. You do not need to over document to justify the level of service that you are going to do. This is the major criteria for the billing and choosing your CPT code appropriately. As you know, the majority of our job as physicians in the geriatric field is seeing the patients, talking to them, and documenting their visit. And by the end of that visit, we need to bill the level of service that we believe is appropriate for our time and the service that we provide for our patient. So we sometimes uh, accidentally over document or under document uh, because there is templates what we use and click or other prior notes we provide and copy and paste forward, and those can be a trigger uh, for inspection and audit. And the message for today is think in ink. Uh, Write down what is appropriate for your patient and make sure that you follow the rules and trying to be clear on your decision thinking tree because everything you do will affect the level of service that you are doing, and the documentation should support your level of service. So some of the changes that happened in the 2021, starting January 1st, 2021, we are no longer using level 1 service for a new patient. So it was deleted in 99201 and no longer exists in the new guidelines. For the calendar year 2021, uh, there are established visit code from 211 to 215, which are the same as been in the past. You are not going to worry too much about the history and physical exam as you've been used to document in the years prior to that. The main level that at this year that defined your billing code level is the decision making or the time. In the past, you have to have 2 or 3 components to promote the level of service, and that is not there anymore. So with the televisits, with the encounters, I mean, it's a big win for psychiatry, in my opinion, because you don't have to listen to their hearts and do that. I'm not saying that you don't have to. I mean, in documentation, when you document it, you don't have to document that you uh, listen or document that there's wheezing or not. If the condition does not important for your visit. So the history.
Sorry to interrupt. I just wanted to add, I think it's also just a win for geriatrics with our higher complexity, with our patients that tend to be multi-complex, that take more time, right?
Absolutely.
I mean, being able to bill based on the time it takes to handle that complexity is a big win.
Absolutely.
I hope it translates into some changes into how we schedule our patients to allow for better handling that complexity.
Absolutely. It should, hopefully it should, you will see that if you bill based on time, which is data complex, which add in geriatric patients in general, you have to have additional liable historian. Most our patients qualify for that, and definitely that there's a code for that you can add that you have used the reliable verification historian. So be able to add that, and hopefully that will pump up your level a little bit more and be able to document and reimburse appropriately for the work that you've been doing.
Can I just ask, when it says visits include a medically appropriate history and exam, I'm assuming that's an episodic exam and not a total exam, right?
So, exactly. So at the new guidelines, you need to document what you did. In the past, we used to say like you have to have at least 9 physical exam systems or organ systems. You have to look at their general, look at the vitals, document their lung and heart and abdomen.
No. Okay.
At this time, if you do not require to do those exams, you are exempt from doing it. They are not going to fault you for not doing it. Especially for a medical geriatric, when you are doing a televisit, it's difficult to put a stethoscope virtually. So they understand that, and they do not mind you not documenting the exam as long as you're documenting the history that help you with the reaching the diagnosis.
Mm.
So, like I mentioned, the history and physical exam are no longer required in the level of service to determine how you document. However, it is important that if you do something, you describe it. And I still teach my residents to do a clinical skill exam because I believe it's important for physicians to understand the those elements. Sometime I have the honor of precepting a residence and saying that the patient's lung exams are clear, and you go to the room and you can hear the wheezing without putting a stethoscope. So it's important to learn those skills. It's not the intention that we forget our stethoscope and not use our brain anymore, our hands or eyes. We need to continue to do that. It just, you need to document it appropriately when you're doing it, not just a template that you feel that you have to fill and put in the chart. So you can use the time, or you can use the medical decision scale. And we will talk about both. In the past, we used to have a time limit on our visit and time restrictions. In the past, it has to be face-to-face with the patients themselves in the encounter, without looking at anything else. And more than 50% of your time should be spent counseling the patient. That is not needed anymore. The new guidelines has changed, and we do not have to worry about the what are you doing with the patients and how you document it. However, you still need to document what is appropriate for medical decision making or a time. Like I said, in the past, for the 1995 and 97 rules, it has to be more than 50% time face-to-face, more than half of it is based on counseling and coordinating the care. Now, it's not the case. It does not have to be face-to-face, and it does not have to be the physician doing it themselves. So the time, I remember, I mean, we spend almost half a day in when I was doing my geriatric patients, take care for one patients, because when they come in for their initial dementia workup, I mean, we have to speak with the staff, we have to speak with the social worker, we have to get translation service, we have to speak with the history, with caregiver, and all that takes time. And in the not necessarily counseling in the past, we just need to collect the information and coordinate the care. Now that makes sense, that we're able to do that, and we can document it, that this is the time we spend speaking with the social worker, with the attorney, with the neurologist, with the daughter that she lives in California, and all that. We're able to document that, even though you are not sitting in front of the patients, as long as you're documenting those time. The problem versus problem address is important to distinguish, because we see it a lot in our patients. When you list in your assessment, at the end of your notes, you're listing your assessment, you need to tell the billers at CMS or other insurance companies about these problem that you are dealing with. And they define a problem as a disease or condition or illness, injury, symptom, sign, finding, complaint, or anything addressed during the encounter, whether you diagnose it or not. So you can say sore throat, you can say cough, you can say shortness of breath, you can say for hearing loss or difficulty hearing. You are not diagnosing anything yet. You don't have to in the problem. In the problem addressed or managed is when you decide to do the strep test or flu screen on these patients, and you decided to, yes, it's positive, yes, I'm going to give you antibiotics, or no, it's negative, it's viral pharyngitis, I'm not going to give you anything for it. So once you address it or manage it, it becomes a higher level. Now, if you are not addressing it and just listing it for the sake of completion, you are not going to get point for it. So if the patient has AFib and you say it's managed by the cardiologist, or patients have depression managed by psychiatrists, and you're not doing anything further for that, you're not going to get money for that. However, if you say depression is stable on his current medication with Zoloft 150 milligram, then by all means you are aware of what's happening. No reported side effects. That's always a good documentation that you are reviewing the medical problem and not only just saying someone else is working on it. I don't have to worry about it.
Just to say it again, especially for the fellows, but also the students, it's not that you are having to change the management for a particular problem, but that you are assessing that problem during your visit and documenting that assessment.
Correct.
Right? Stability, etc.
Yes.
That's really important because we, like in our clinic, for instance, we're always assessing blood pressure when patients come in, but we may not change the management, but we measure the blood pressure, we look for orthostatic hypotension, and we should document it as such, right? Because that's part of our visit.
Absolutely, absolutely. Yes. So by all means, your patients have high blood pressure, you document that their vitals are good and you're taking their medication, no reported side effects. That's all what you need to do, and you get money for it. If you are sending your patients without any reason, you don't get money for it. If your patients come in with their diabetes and dementia and seizure, and they say, can we send us to neurologist because my seizures medication is not working anymore, and you just send them without writing anything on the referral note, then you're not going to bill for it. You cannot claim it. However, if you say seizure uncontrolled, patients will need referral to neurology, then that is a problem that you are addressing or managing or co-managing or referring to. So you get money for it or points for it instead of just sending a referral without getting any point for it. So the medical decision making, there are three levels that we look for when making those decision making and establishing the diagnosis. Your patients, you listen to the patients and you diagnose them with depression or diabetes. That is one thing that you establish a diagnosis now. And then you decided to run an A1C and get creatinine to see how bad their diabetes is. That is the assessing side of the condition. And then you decided to say, well, they are going to start metformin or insulin or this and that. Then that is the selecting management option. So those are the three levels that comes in your mind when you making those decision trees. So those are how you bill for your service nowadays. You need to tell us what exactly you're doing and what you're thinking, so the billing will accept that. So in the past, it used to be how many conditions you listed and how much complicated those data that you are dealing with. Now you need to address those conditions that you listed, not necessarily, like Dr. Reinhardt said, you don't have necessarily to change or manage. You can co-manage their depression, you can co-manage their diabetes. I agree with it. Seems to be tolerating it. No reported side effects, in good control or uncontrolled. We need to speak with the cardiologist for their blood pressure medication, those kind of things that reflect that you are aware of their medical problem and you adding to the decision tree. And how serious is their management and the patient's problem is going to play a significant role of your decision-making tree. So in the Levels 2 to 5, like I said, for level for element 1, you said in MDM we have 3 levels. The first one, first element, is the number of and complexity of problems. So for level 2, we are talking about self-limited minor problem. Someone came, they scratched their knee after a fall, and they want to reassurance to go back to school. I mean, by all means, this is, I mean, straightforward. You don't have to think too much about it. Nothing happened to them. They're young, they're active. You're good to go. Nothing serious. In level 3, you need 2 or more of those limiting minor illness or 1 stable condition illness, like they have hypothyroidism on treatment on the same thyroid medication for years, no side effects, no change. So that, if you just did that, it's level 3 already. Or if you are talking about an acute, uncomplicated illness or injury, they fail, they are hurting their shoulder, you prescribe them some ibuprofen to go home with, and that's the end of it. You don't suspect any fracture, you don't suspect any injury, you examine them, everything looks good, checked out to be normal. For level 4, we need an acute, we need a chronic illness with exacerbation. So if their COPD is flaring up, or if they have diabetes and you put them on metformin and now they are having a side effects with nausea, upset stomach, and you need to address that, that's why all of a sudden level 4, 1 condition, COPD exacerbation, that's good, level 4, or depression and now they are having side effects with the nausea because the SSRI is too much sedating for them, you're already on level 4 with that. Or if you have 2 chronic conditions that's stable, no problem. Their depression's under control, they are on medication, you're treating them constantly, and their diabetes is stable. Or if it is undiagnosed, new things that you are not 100% sure what it is. So they tell you, hey, I have upset stomach, I'm taking my medication, and I'm not sure if the metformin is causing me the upset stomach, or this is the flu, or is it COVID, or is it metabolic acidosis? I don't know, doc. You are the better person to tell me what's wrong with me. So this, you don't know what exactly that is, so that's level 4. You are working it up, you're not sure how serious it is. If there's something serious that is going to be requiring further treatment, or just a side effects from medication. Or if you have an acute complicated injury, they fail, they broke their hand, you need to send them to an orthopedic for repair. That's a complicated condition. Level 5, obviously, if they are going to have a serious life events that you believe that they are going to die or something serious happen to them, and you decide to send them to the emergency room because does not, your patient is septic or about to be septic, or they having a complete abortion, and you need to rule out any topic that if you aren't treating, it will go into a shock. So all those, or patients coming with a stroke, and you're going to send them to the hospital because you are afraid that this will going to change your management. Obviously, if they fail, they broke their hip, or they have penetrated trauma to their chest, and you're feeling that they are going to have injury that might be threatening to their life, that's major fracture or major trauma that will obviously need to be addressed in the hospital. So you send them to the hospital, level 5. The element 2 that we would like to talk to you about is the amount and the complexity that you are reviewing and analyzing. You'll have tests and documents or independent historian. You'll have you are reading the results and interpreting on your own, whether it's AKG or chest X-ray or anything else, and you discussion with the other physicians. That's a level 3. So we'll talk about these data and what the definition of CMS for these data elements and how you can review those definitions. So when they're talking about tests, they are talking about any imaging, any lab test, any psychometric test, like if you did the PHQ-9 or the GAD score, anything, any psychological or psychometric or physiologic data that you are doing is a test. I remember the single or multiple test defined per their CPT code. So if we're talking about comprehensive, excuse me, we're talking about comprehensive metabolic panel. Obviously, it has the sugar, it has the sodium, it has potassium, it has kidney function, it has liver function. It has more than one test in it, but it all lump sum under one CPT code. So it is considered from CMS as one test. However, if you're doing a lipid panel and liver test, or basic metabolic panel and liver function test, those are 2 tests, and each has a point for it.
Dr. Abizit, well, while we're on the test, one of the things I think that people don't often realize, in fact, many providers don't realize, is there are some tests that we consider routine that Medicare does not reimburse for as screening. They have to have a diagnostic use. One of the more common ones that people are still using is urinalysis, but it is not covered. There has to be some therapeutic reason for doing it, and there aren't many anymore. There used to be in the old days, we didn't have quite as many sophisticated testing opportunities. So that's something that people need to be aware of. And it's hard because what happens is that the primary care provider in many cases will order it, or somebody else will order it. And then the patient gets stuck with the bill, not realizing they signed that statement saying they would pay. So it gets messy.
True. So obviously do not order any test or any service unless it is medically necessary for your patients. You just don't do it to add a level of service and increase your reimbursement. So that is a no-no. You do not do that for just the sake of it. If you are thinking of test because you're doing the UA because you want to rule out pyuria because they or UTI, by all means. If you are doing it to check their urine because they're diabetic, by all means. But don't just order throw a bunch of labs just to increase the level of service. This is a very good point. Thank you for bringing that up. Your patients, our patients, most of geriatric patients on very limited income, and when they sign their ABN and all sudden they are receiving a bills, they will not be happy with you. And either they will leave a comments on Facebook page for you, or they'll stop coming to you. So that will cost you more than caring and increasing the level of service. The other data element that CMS look at external data. So anything that you receive from a place that you did not do the test in-house. So if you order the lipid panel and you send it to a LabCorp request or the hospital, then by all means, when you receive it, that's an external data. If you send them out to their kidney doctors or their endocrinologist, and you review their consult notes, by all means, this is a different data level that you are reviewing. External physicians, like I said, if it's not the same group, not the same specialty, If you are worried about their diabetes and you send them to the nephrologist to check on their kidney, by all means, you do that. And obviously, if you are going to obtain a history, many geriatric patients, they have a guardian or surrogate or reliable source of information that will be able to give you that also another level of service that you're able to add to your patient's level of billing. So those are the how we look at the amounts that we need to analyze. Each one of these levels must need a supporting evidence to go with it. In level 2, you don't really need to do any extra efforts. However, for level 3, you need one of these two. Either you have a good assessment history, so you ask them about their depression. Are they having any side effects of their medication? Are they taking their medication regularly? Are they feeling any better? Do they have any sleeping problem? All that, if you document that, that is a level 3. Or what you need to do is you are going to review the notes from an external providers and ordering or reviewing a test. So if you worry about their diabetes and you're checking their A1C and you're looking at or you're checking their urine microalbumin because the endocrinologist did not do that, and you're reviewing the endocrinologist note, by all means, this will qualify as level 3. In level 4, in the complexity of data review, you need to have one out of these 3 elements. So either you need to have you're reviewing a test or ordering in a test like A1C. You are reviewing the endocrinologist note, and then obviously you are reviewing the data with from the patient's or his independent historian. So if you do all 3, that will give you a level 4 all of a sudden. Or you can order a creatinine, and you check in what their diabetes look like for diabetic nephropathy, and you decided to say, well, this means based on the microalbumin ratio, I think you have stage 2 kidney disease, and I believe that this is where you're at because of your diabetes. So that's level 4. If you picked up the phone and you spoke with the endocrinologist, and or the nephrologist, they say, hey, well, this patients have kidney disease, put them on metformin. Do you think we should keep it the same dose? We should discuss it. If you just did that without other tests, then obviously you are a level 4. So one of those 3, either one of these 3 by itself, they qualify for a level 4. For level 5, you have to have 2 of the 3 that we talked about. So if you did 1, you are at level 4. If you do 2, you are at level 5. In the rest, like I said, if you think that the patients will have no side effects of the treatment plan, then by all means, it's a low risk. If you believe the patient's life or organ system is going to be suffer or damaged, then that is level 5, and anything in between is how we define it. So the probabilities and the consequences that you expect to happen from the complications, the morbidities, mortalities, anything that happened to your patients when you're doing the decision-making tree, that's what help you establish the correct level of service. So this is the decision-making. If this is straightforward, patients fail, a young guy, no problem, running like a horse, no, you don't have to worry about it. However, if your geriatric patients fail, broke their hip, you worry about them dying, send them to the hospital, that's obviously a high decision making. All right. And this is the cheat sheet for the times and for the level of service that you do it. This is, you see, it goes from 15 minutes to 29 minutes for a level 2 on a new patient, or 20 minutes for a level 3 patients. It is established versus new. And the new patients usually have higher requirements of time. And for any extra 15-minute, you use the extra CPT code for that. So you are using the total times for it, and then you do it. If you are using let me clarify that for a minute. If you are using a billing by time only, you use the 99417 for each 15-minute above the extra limit that you have. If you have a level 5 established patients, you spend 55 minutes. Any extra minute you do after that, and extra 15-minute increments, you do the 99417. If you are using the prolonged visit, then you do the G2212, and that is based on the time has exceeded this time, and then you spend extra time for it. So that how you review it. And this acute annoying slide that I hate, but Dr. Reinhardt reminded us not to do this busy slides, but could not shrink it any better. I apologize for it. They tell you about the elements of what is acute, what is complicated, what's not complicated. So in a nutshell, what that's supposed to tell you, if you are given a medication and the medication requires monitoring, that's obviously lithium, for example, for your psych patients, that is very dangerous drug. You need to monitor it. That's a level 5. You need to remember the that. If you are having a guardian, whether it is a parent or a patient having psychosis or dementia, you're adding this, that's by all means will increase your level of service when you manage those patients. So the time office outpatients, like I said, you can use the code differently starting this year, and you can use it whether or not you are coordinating the care or consulting with someone else, as long as you are doing it at the same day of service, and you can add it to the other level of service. And we defined the time from the encounters. That's include the face-to-face and non-face-to-face. And usually, if we talk about to the neurologist, or you talk to the social worker, and you spoke with the documenting, and spoke with the behavioral health specialist, and you spoke with the rehab center, and you spoke with the physical therapy place, all those will be counted as non-face-to-face activities, but still counted on your overall time. And if you are doing a test, and waiting for a test, however, if you are doing, you have a in-house test, whether it is a UA or a CBC, and you're waiting for the machine to run to do the test, that is not a time that you are going to bill for it. So be careful with that. This is your professional time. So this is when you are coordinating the care, when you're referring patients. Those are the things that you are considered a professional time. And a physician can include those, and those are billed. So the times separately reported. If you've done a test like an EKG or CUA, this is not, you should not bill for this extra time. And your time, because you are billing for the test, you cannot bill also for the time waiting for the test. However, if you are not billing for the test, you're sending it for an X-ray, that's different. You arranging for them to have the MRI because their insurance, speaking with their insurance, getting their prior and all that in the same day of service, by all means, you can do that. So this is the time that has changed for this year of service. So this year, the time a little bit adjusted. So you can see level 2 to 5 or 1 to 5 if it is established or new, and the time that are expected for each level of service. Last thing, our prolonged visit that we sometimes have to use, and those will be reported along with the level 5 service. And this is when you use it, like I said, we use the additional level of service for each 15 minutes beyond the what is typically on level 5. So if you spend 2 hours, then you report your level 5 and then 2 of the G code. And this is the difference between the prolonged service and add-on the service. If you adding the 99417, or if you're Medicare patients and using a prolonged visit. You do not report the G code for anything less than 15 minutes, and try not to mix between both. The 99417, it is a prolonged visit. The G221, sorry, the G221 is a prolonged visit. The 99417 is the added code. And this is the new patients when to use the prolonged time visit. And like I said, if you're spending a 90-minute, you do level 5, and then the 99417 time 2. If there's more than that, you just repeat it for each 15 minutes. Same thing for Medicare patients or established patients. So make sure that you read it. This is all the time included of the visit. Reporting by the patient, the physician, and his staff that working on the care of the patient. I know we used it a lot of time in geriatric, initial geriatric assessment, because that is the need. There is a need for it, and your time will be hopefully reimbursed accordingly. And this is all I have to talk to you today, because I thought we might not be able to cover everything that the government changed. And with the last 10 minutes, I decided to leave it for Q&A. If you have any questions, extra reading, recommend for you to go over AMA website. They have tons of new updates. and I'll give you the link where I get my presentation. And as a disclaimer, I am not a certified biller or coder. I am not a I'm not a Medicare or CMS guru by any chance, or I'm not reference to any of them. I'm just presenting what I practice, and I'm sharing what I learned with you. And I'm very grateful that you guys decided to spend 1 hour to listen to me talking. Any questions?